my task is really to talk about adapting to cancer. What are survivors telling us in this context? And I'm going to cover several broad themes. I'm going to talk a little bit about why is cancer survivorship such a hot topic? Why are we interested in this? How has this come to be such a phenomenon, not only in the research arena, in the clinical care arena, but actually in the media and the press? I'll talk a little bit about who our survivors are today, what survivors are and what survivorship research is telling us, what are the lessons to be learned, and then finally, what are the implications of this for clinical care? There's no question that in the last 5 years, there's been an enormous surge of interest in the area of cancer survivorship, in particular highlighted by 5 publications that have come out from the President's Cancer Panel and IOM and the Lance Armstrong Foundation and Center for Disease Control and Prevention, discussing the challenges that individuals face once treatment ends, where the research needs to go, what we know clinically, what we don't know clinically, where we need to be directing our attention. And when we look at this and say, so why phenomenologically is this happening right now? If you pick up a newspaper at any given time, you'll see an article written up in that. In fact, in my hotel room last night, there was a little précis from the New York Times that had a whole piece on cancer care for survivors, just in the New York Times, clipped out from yesterday's press. We can't turn around, but there isn't a public figure talking about his or her experience of this event. And so what you would have to conclude is this has become a phenomenon because we have a growing population of survivors. In 1971, when Nixon declared war on cancer with the National Cancer Act, there were an estimated 3 million cancer survivors in this country alone. Today, that figure approaches 10.8 million individuals living with a history of cancer. I have to tell you, when we put that figure out, one thing you need to know is that it's a wonderful number to have, but all that tells us is how many individuals estimated are there in this country who are alive with a history of cancer. What it does not tell us is the health status of that population, where they are in what we call the cancer control continuum. How many are newly diagnosed? How many are in active treatment? How many have finished their treatment, doing reasonably well, few side effects? How many are struggling post-treatment with major chronic effects of their illness and other conditions? How many have recurrent illness or have progressive disease? We don't have a system yet that will allow us to tell us where people are in that trajectory. And that's a very big challenge for us if we're going to plan healthcare going forward. Who is going to be in those different segments, and what does that mean for healthcare delivery? A number of things have contributed to this remarkable progress. Certainly earlier detection, new screening technologies that are available, more application and uptake of those, although it's worrisome to see news reports coming out and saying that women are now having fewer mammograms. We need to keep an eye on some of those. Certainly newer and more effective therapies, often combining multiple techniques and drugs and interventions to achieve cure and control. More effective adjuvant and maintenance therapies, and better supportive care, helping people get through fairly demanding or toxic regimens, and hopefully growing attention to the long-term surveillance of individuals who are living longer after treatment. In terms of length of survival, more individuals can expect to be here long-term following a diagnosis. 65% diagnosed today as adults will be alive 5 years from now. So again, you have to be thinking differently about the care that's delivered. For pediatric survivors, that figure is actually 75% at 10 years are still alive. Currently, in our prevalent population, this represents 14% of survivors were diagnosed 20 or more years ago, so we're talking about people living lifetimes following this diagnosis. And one of the things that many people recognize when they look at this slide is that while male and female survival looks very comparable in the front end here, by the time you get to 10 years, we're beginning to see women pull ahead, more females surviving with a cancer history than males. The major driver behind this is that women develop cancers that are more readily detectable, like breast cancer and cervical cancer, also cancers that affect a younger population, so they have more time of survival following a diagnosis than some of the adults, where prostate and colorectal are diseases of older males. In addition, women have lower all-cause mortality, so they are outliving men because they are living longer regardless of whether they have a cancer history or not. And as I jokingly tell my colleagues, in all deference to our beloved males who are in the room today, women are just better designed. Cancer is a disease associated with aging. Single most important risk factor for developing cancer is getting older, something over which none of us have any control. And actually, what we would like to do is to get older. That is our goal. Die young at an old age. That's kind of the mantra now. But this is an important issue for us when we start thinking about the fact that we have an aging population. Those of us who are baby boomers born between the years of 1946 to 64 are fast moving along this healthcare pipeline. The first boomers will turn 65 in the year 2011. We're going to put a lot of pressure on the system. We want all of you out there figuring out how you're going to take care of all of us who are going to have a cancer history and plan to live long-term following this. Having said that, I will tell you that the vast majority of the research that's been published to date, the studies that have been published to date, are in a population under the age of 60. Even though those 65 and older represent 60% of our prevalent population, we have very little data about what their outcomes are like, what their care needs are, what the specific risk factors they have for consequences following their treatment in here, or what kinds of treatments they should be receiving. In fact, for many years, the clinical trial system excluded you if you were over the age of 60. You simply, age 60, you are not offered a clinical trial. That's no longer the case, but we have a lag time now in trying to catch up with that and designing clinical trials and research methodology that addresses the fact that we have an aging population. So if you sort of summarize where we are now, the majority of individuals, as opposed to 1971, the majority of those diagnosed today can expect to be here for years over time. We know that treatments have become increasingly complex and multimodal, increasing the demand for the need for help managing all of this. Not less information, more support is needed to get through these. For many, cancer will become or has become a chronic illness, requiring multiple visits over time, different complications over time. We also know that most patients receive their care in a community setting. So one of the challenges for centers like Yale, big comprehensive cancer centers, how do we push that state-of-the-art science out into the community? How do we deliver standard of care out where people actually are living, and for most of whom, where they're actually receiving it? And we also know that cancer is not a disease that affects just an individual. It often affects a family, frequently a community, a social network in here. And we need to be attendant to that. We know that family members are very important members in this whole dialogue about cancer care, and involving them in that care is going to be very important. So what are the lessons that we have actually learned from all of the work that's been done here? And I'm going to say that there are 7 that I would like to propose to you today. And the first of those is language is important. In 1986, a group of 24 individuals gathered in Albuquerque, New Mexico, cancer survivors, medical oncology specialists, other oncology professionals, individuals who ran support programs for patients and family members. And the intent of this group was to say, we're a growing population of individuals, and we want to know what happens after treatment ends. What can you tell us about this science? But more importantly, we need to look at the language of the medical culture. At that time, 1986, to be called a cancer survivor, you had to be 5 years disease-free to even get that label. Lots of oncology professionals wouldn't even tell you you're cured at any point in time, and we still back off that quite often. It's still very problematic for some people to say, yes, you're cured. When am I cured? Well, maybe never. But what this group of individuals said, we have to change the language because we need to change the care. So what they proposed was that they would philosophically embrace a new definition, that an individual could call him or herself a survivor from the moment of diagnosis and for the balance of that individual's life. Now, their intent in here was not to label someone. You are a cancer survivor, like you're a diabetes survivor, you're a heart attack survivor. The intent was really to bring attention in the medical community to the need to address the quality of life, personal, human issues related to this disease at the time of diagnosis, and not wait 5 years later to decide, gee, I would have liked to have had children, but all of these regimens are so toxic, and we've heard Leslie tell us that we can't have children anymore. You have to make those decisions early on. You can't wait 5 years to sperm bank. You can't wait 5 years to take those drugs out of a regimen. You can't wait 5 years to decide, actually, I would have liked to have spared this limb because I want to continue my athletic career. You can't wait 5 years to find out that the drug you received was toxic to your lungs and I have no breath capacity anymore. I can't play the flute. That's not acceptable. So what they said is we are going to use this language to change how care is delivered. And I would have to argue they were monumentally successful, even though we might not all embrace the term cancer survivor. It has simply and very certainly changed the culture. And importantly, when they put that definition out, they also recognized that family members and caregivers needed to be under that umbrella. So they consider family members and caregivers, secondary survivors if you like, equally important in the outcomes. Very important definition. Lots of people, as I said, their intent, the coalition's intent was not that you labeled yourself, but rather that you would be able to argue for your personal needs in the course of care. And for many individuals, this was a message of hope. I think of Peter Jennings announcing on air after his lung cancer prognosis saying, I'm glad to know that I'm a survivor. Whether he was going to outlive his disease or not, he felt that was very important to him. It gave him hope to move forward with that diagnosis. Lots of other groups call themselves other names. Some people say, I'm not a survivor, I'm a thriver. I'm taking this and doing something very different with it. I'm an advocate. One of the groups that I work with in the greater Washington area was an African-American group of breast cancer survivors, and they considered themselves the blessed because they were going to go out and tell all their sisters the value of early screening and mammography in their community, and they felt that they had a mission then with this. I think that all of us sitting here would agree that there's only one word on this list we would like to see disappear, and that's the victim word. I think the other my other pet peeve in here is changing the language in here around the treatment arena here. Patients don't fail treatment. Our treatments fail patients. It's still very deeply entrenched in our medical community. Patients do not fail therapies. We have ineffective therapies that are offered to them to which they are not responding for whatever reason, but they don't fail. I'm also not the breast, lung, colon in room 5 down the hall. I'm Julia Rowland. I'm married, I have 2 kids. My son graduated last weekend from Reed College in Portland, Oregon. I'm very proud of him. I hope to see him do well and get married. I have a career I love. I want to continue doing that. I want to have enough breasts so I can play my flute. So these are things I want you to consider when you see me. I'm not the breast, lung, or colon in room number 5. Language is important. 2, making this transition to post-treatment is stressful. As a mental health professional, we spend a certain amount of time in our training learning how to terminate therapy. You work for many months or weeks or a certain amount of time with somebody in psychotherapy, and one of the most important elements is making that transition when you're going to end that treatment. So we spend time talking about that, anticipating it, learning to work with the patients that we see in negotiating this. Does this happen in the cancer arena? No, you're treated for months at a time and it's bye. See you in 3 months. So why is this stressful? Oh my gosh. Is it going to come back once you stop giving me all these drugs? Gee, there's a benefit to taking tamoxifen. At least I'm doing something. Or this aromatase inhibitor. If I continue to take a medication, maybe I'm doing something. But if you stop it all, is it going to come back? Who's going to monitor me? When I have that call in the middle of the night, when I have a fever, when I have a cough, whatever it is, this ache or pain, I used to call my nurse. I could pick up the phone. I knew she was there. I knew he was available to me. I knew who to contact. Who do I call about all of this? All of these people who understood what I was going through, this clinic of very caring individuals, knowledgeable, had been there, knew that. Even the patients and survivors I met in that setting, that wonderful resource available to me, knowing what I was going through, they're not going to be there anymore. I'm feeling crummy. I felt pretty good coming in, actually, but now I feel really beat up. I felt worse going out than I did coming in. That's what the treatments have done for me. And my family, oh, by the way, they want the person back who was there before. Tomorrow. Oh, you're done, honey. Great. You can take the garbage out now. You can do the carpool. Assume all those roles. I think it's very important to acknowledge the fact that these transitions are difficult, to plan for them ahead, figure out who's going to do the follow-up and care, talk about the fact that while it's a wonderful, exciting, congratulatory period, it can be stressful and frightening. Detoxify that transition phase where we really don't do a good job of saying what's next and what's going on. Help people prepare for that. Very important to make that transition and make it work. Lesson number 3 that we hear time and again from the survivor population. Fine, you told me I'm cancer-free, but boy, I do not feel free of my cancer. Because it ain't over when it's over. In fact, it's lingering. It goes on for months and weeks afterward. We know that cancer affects every part of an individual's functioning and health, from physical, medical, to psychological, to social, the existential and spiritual. Some of these effects are acute. They go away once treatment stops. Nausea, vomiting, hair loss, hair comes back, neutropenia, whatever it is. The post-surgical pain goes away. Some of these, though, as we follow survivors over time, we're realizing are persistent in ways that we didn't anticipate. Chemo brain, I can't remember a thing. What's with that? The fatigue, does this go away? When will I have my energy back? How long does this take? In my clinical practice, what I used to tell individuals whom I saw was, I said, think about the first symptom you had that was your indicator that you had this serious illness, and then add up all the time to the very last treatment that you received, however many weeks or months that was, and then parcel that out on the other side as how much time you're going to need to recover. It's kind of like transcontinental flight where they tell you need a day for every hour, time shift. You need a day for every day in treatment just as a framework for yourself. So if that whole process took 9 months, think about 9 months at least to allow that space for recovery in here and build that in. Very important kind of anticipation in here. We also know that patients of all ages can be affected by these kinds of problems. Some survivors have very few, some have everything in the book and then things you hadn't thought were in there except in the small print in the consent forms. The degree of risk is very hard for your medical team to predict. We don't have good measures and metrics of this. We certainly know that these contribute to the burden of illness, not just in financial costs, but in human costs of illness. Sometimes there can be what we call long latencies. It may be months or years later, these late effects that we really worry about, cardiovascular disease, osteoporosis, second malignancies, that we have to be monitoring for long term. It's not over when it's over. While we know that second cancers are the most life-threatening, they're not the only thing we have to be worrying about here. As I said, stroke, cardiovascular disease, other kinds of major life-threatening consequences that need to be monitored. And the reason we need to monitor those is because early interventions have the potential to make a difference in here. What we do know from the intervention research, and this actually says psychosocial intervention research, but you could say intervention research in general, is that the main challenges that we have as a delivery community is who should deliver what to whom, when in the course of care, and critically, who's going to pay for this. I frame that in part by the psychosocial because we have a particular disadvantage in the psychosocial community because we have very little research that's been conducted with economic metric outcomes. So in other words, we can show that we can improve quality of life and function, decrease depression and anxiety, increase capacity to enjoy life, to be back at work. We never tied it with any economic outcomes. How many visits to the doctor? Are you reduced medication here? Are you back to work sooner? Are you able to work fuller days? So that when we come back and say we want to deliver this care, everybody says, well, fine, who's going to pay for that? If I could show your insurer, which we probably could if we had the data that it reduced medical care visits, because if I'm taking care of your anxiety and depression, you're not the revolving door back and forth to your doctor because you're actually depressed and you need that treated. That's something we can treat very well. And you're not anxious and calling up all the time because you're worried about this symptom or that cough or whatever's going on. If we can intervene and take care of that, we may reduce the medical care costs. We have not collected that data, so that's a problem for us. So lesson number 4 is that despite the risk of some of these adverse outcomes, what we know time and again, and survivors tell us when we give them the opportunity to talk to us about it, or those open-ended questions on all those questionnaires that survivors have so graciously spent time filling out for us and being willing to share with us their experience with, tell us how resilient people are. Remarkably, incredibly resilient. Doesn't matter what toxic drugs regimen challenge you put before them, the majority of people get through it. Remarkably get through it, and may be very proud that they got through that on the other side. Pleased with themselves that they were able to tolerate this, do this in a fashion that made them feel good in ways that they didn't think they were able to do. As a researcher, having been in this field for a long time, we started out in this arena back in the 1970s looking at all the ways that we damaged people. They were disabled, dysfunctional, dismembered, disfigured. All the negatives we could possibly think of. And after a while, we got wise because we would do those little open-endeds in here and say, well, by the way, is there anything else you want to tell us about your experience? And what we began to see was this sort of sense in here, increased mastery and self-esteem, grateful to be alive, and enhanced appreciation of life. It's this whole new arena of research opened up, this sort of benefit finding, that people make sense out of adversity, that they find the silver lining. It doesn't mean people are Pollyannish. The negative things travel with the positive things in here. But what you learn and you have the capacity to experience is this incredible deepening of life experience that many people report as a consequence of surviving these illnesses. Very different mode in here, and one that, as I said, has spawned a whole new area of research. Lesson number 5 is that we actually have identified a number of key factors that are time and again in the literature and the research data associated with optimal adaptation. And these are as follows. First and foremost, accessing state-of-the-art care. Very critical. The data all shows you go to a high-volume center for your surgery, you go to people who are knowledgeable about it, you are on a clinical trial, you are taken care of by people who are well-trained in this area. Statistically significant differences in survival outcomes for individuals who are able to access state-of-the-art care. So the challenge for us nationally is making sure that we can make this available to all sectors of our country. The second is being an active participant in one's care. This doesn't mean you have to make all the decisions. So we've heard a lot today about decision making. The reality is when some of us are diagnosed with cancer, we don't want to make the decisions. Tell me what to do. That's okay. You can actually delegate that authority, your physician or a family member in here, but you do need to be engaged in that care. Doesn't matter who's necessarily making the final decision, you have to be engaged in the process. Again, all the studies come back and tell us that people who are active, involved in their care, committed to participating in whatever treatments they're having, doing what they can for themselves, and the underlying theme in here is maybe even being physically active, because the data on physical activity is beginning to be more and more compelling. Literally active in your care and physically active may be important. The third element in here is having and using a social support network. And I would just say here, at a minimum, even perceiving that you have the support available to you. So even if you don't exercise it, the people come back and say, if you needed someone to take you to the hospital in emergency, would there be someone available to you? If you needed someone to bring you a casserole to the house, would there be someone available to do that? If you needed somebody to do something for you at work, would that happen? Just believing that there is a network available to you is very important. And this is not unique to cancer as a health condition. Social support, again in the literature, time and again, is a buffer to adverse health outcomes. So having it and building it, very important. And then a final one down here that we see in the literature and various iterations is finding or having a sense of purpose or meaning in one's life. And that's going to be very different for different individuals. Some studies suggest that it's a religious affiliation, that you have a spiritual community to which you ally, and that's important to you. Others are built around, I have tasks I need to do. I have somebody or some care or thing I need to do, that kind of sense or purpose and meaning that helps frame things, that looks in the literature as though it's very important for outcomes. A final one in here I'm going to throw in, it's still newer in here, but it is provocative, is possibly this area of learning to express yourself. There's been work by David Spiegel and also Jamie Pennebaker, who does writing essays in here about the emotive quality, being able to talk about your experience in some way. It may be partly that this process enables people to find meaning and make sense of what's happening, so it may be essentially a sub-theme under the purpose. I would challenge us to recognize, however, that given this knowledge base, consistent findings in the literature, we do not systematically assess people or ensure that they have access, but assess people with regard to these or build delivery systems and healthcare systems that allow people to maximize. So if you don't have social support, we need to monitor that, step in and help us do that. If you're lost and unsure about what this all means, can we help people negotiate that and figure it out for themselves? Something, again, for us to think about if we're going to optimize health outcomes. And in that context, lesson number 6 is cancer for many may provide that teachable moment. As I said before, people come into this illness often unaware that they're at risk. They get a diagnosis, feels for the most part by people as it's coming out of the blue, but it does open up that opportunity to say, what was it that was happening to me before or I was doing before that caused me to develop this illness? We are all rational creatures. We're always trying to understand, particularly in this country, we're always trying to find either the pill or the drug or the reason why we did these kinds of things so I can change it and make it better. There's not always a simple solution in here, but there is that drive to do something different about it. So what survivors are consistently telling their healthcare providers is, I want to reduce the morbidity and mortality attached to this disease. Tell me how I can do that. I'm expecting you to deliver that care, to help me figure out what I need to do. I'm worried about my family. Do they have the same genetics, environmental exposures, health behaviors that put me at risk? Can I change those in some ways? How can I engage in this? And the reality is survivors are already doing this. They're going to change their diet. They're going out and trying herbals. They're doing Tai Chi and yoga and Qigong. it's happening out there. Whether the medical community does anything about that or not, I would posit that we need to be on board about this, because this is a very important time. And it's very important because our cancer survivors are going to actually drive the system potentially to deliver better health care for all of us, because they're forcing us to think about primary prevention. What do we need to do, all of us, to promote our health and well-being? And how can we incentivize the system to do that? Pay doctors to deliver this care, make it something that you and I all want to engage in, because it's going to be beneficial to us in some way. And as you can see here, colleagues at Duke, Wendy DeMark and colleagues, have said that just some of these basic lifestyle interventions can have profound effects on issues like depression or fatigue, changes in body composition and body image, functional status, comorbid conditions. Something, again, we aren't taking advantage of yet in a systematic way in any of our cancer care delivery systems. And finally, and perhaps most important of all, we need to listen to survivors. Listen to what they're telling us when they come back and tell us, this is a problem, I need help with thus and such. We need to listen, and we need to ask. If we don't, they're going to be in our face anyway. So, and there's nothing more powerful than a cancer survivor lobby. One of the things I learned very quickly when I went to testify down on the Hill with a group of individuals at this table, there were 4 survivors and me, and the first thing you do is never speak on a panel of survivors. Just shut up and say, here's my testimony, I defer my time to my colleagues here on the panel, who are going to tell it to you anyway and tell it like it is and be far more compelling than any of the statistics I could possibly show you that are coming out of the Cancer Institute. So what are the implications of all this for survivors' care? I think there are several. Some of my early work was actually in pediatrics, and my early cancer work was actually in the pediatric setting, and then I transferred up to the adult setting. And when I made that transfer, I realized that there were very different cultures in pediatric care and pediatrics and adult medicine. And so these lessons I've learned are actually what I learned in pediatric oncology, and they are as follows. In pediatrics, communication is everything. If you're talking to a 3-year-old, you've got to change your language. It's going to be very different than what you tell a 10-year-old or a 15-year-old. Do we do this in the adult arena? No, we just talk at you and we hope you understand. We never ask you, did you understand what I just said? Would you like to talk back to me and tell me what you thought that medication schedule was going to be and what was your understanding of what was just said? And oh, by the way, if you didn't bring somebody with you, half of what I told you is gone anyway. The second is we need to pay attention in pediatrics. We're always thinking about the child's growth over time. When in the cancer treatment this child is treated, what that might affect in terms of his or her developmental outcome. We need to be doing the same in adults. We call it developmental psychology. It used to be child psychology because we didn't think you grew and developed after the age of 18. You do. And we need to be attending to that. So developmental psychology, the subtext there is womb to tomb psychology, because we know it starts in the womb and goes to the end of your life. We need to be attending to that. What's important to you? What are you going to return to? What are the standards and tasks that you want to achieve after this diagnosis and treatment? What are you going to be able to do afterwards? We need, as I said, to plan for transitions. We always do this in pediatrics. We need to monitor and promote well-being across the survivorship trajectory. Our healthcare system in pediatrics is all about prevention. Seatbelt use, sunblock use, what are the developmental tasks your child is experiencing? How can we make sure that you get all the immunizations? You get to be 14, you fall out of the medical care system unless you're an athlete, and then we do a couple more tests for you while you're still in high school. You get to be college and you're uninsured, or you have terrible insurance and you're not going anyway, and then you're a young adult and you're invulnerable, so you don't get any medical care. And then as you're an older adult, it's all chasing the chronic illness that you already have. We don't have a system that pays for prevention. That's why I made the point earlier. I actually think the whole survivorship movement is going to position us to help change medical care in this country. We desperately need more attention to healthcare promotion. The fact that we have a sweeping obesity epidemic across the country is very worrisome. The fact that we have still rampant smoking rates and we haven't gotten on top of the tobacco industry is very worrisome. We need to be engaged in this. None of us are engaged in this. We're not told we need to do this. Show me the incentives here. Pay my physicians to help me do this. We need to be doing that. And most importantly, you never treat a child outside the context of the family. It's all about family. You're taking care of the parents, sometimes the grandparents. You're always looking at the siblings to see what's happening to them. You get to be an adult. That whole family may be with you in the waiting room. I'm sorry, HIPAA says we don't get to talk to you. I'm only going to focus on the patient. How helpful is that when we're expecting those family members to monitor symptoms at all, perhaps call, perhaps make sure that this individual's taking medications, following complicated orders that we may have, we don't do the outreach to caregivers, and caregiver burden in this country is going to be increasing. As you saw the earlier statistics, we have an aging population. Many of us will have multiple cancers, not just one, and it's going to be chronic, and you caregivers are going to be taking care of us. So we need to make sure that we're taking care of you. Ultimately, what we want to do is change the culture of care so that the patient is as important as the tumor. This is where we're headed. I hope we get there very quickly. I think this is an incredible moment in time. We have growing attention to survivors' long-term well-being, and follow-up care is reflected in reports, as reflected in centers like Yale that are establishing survivorship programs, looking at how they can deliver this care in a better way. We have a growing number of clinicians and researchers who think this is an important area and investing their time and efforts in trying to map out the evidence base for what we need to be doing. And we certainly have an articulate and effective advocacy community, and we know the power of survivors' voices. I have the privilege of serving in an office that is here because of advocacy. Established in 1996, the Office of Cancer Survivorship is your office, your public dollars that are going into this. That's why when Leslie says she talked about the grant things, we always hammer our researchers to, whenever they make presentations, to say, make sure people know these are public dollars that are paying for it. This is your tax dollar funding all of the research studies. Most of them, or DOD, also is your tax dollars at work here. And the reason Mike, I'm going to point to Mike, he has DOD money, Department of Defense money. Why? Because breast cancer survivors went down in the early 1990s, lobbied Congress and said, breast cancer is an epidemic, and what are you going to do about it? And Congress looked around. We weren't at war at that time. They figured, 1B52, we'll just transfer it over here. Breast cancer research. And the Department of Defense said, don't take it out of our budget. We'll put a little line item in here on cancer research. Consequence, years later, they're one of the biggest funders of cancer research in the country. Department of Defense, breast cancer, go figure. Actually, they now actually also fund prostate cancer, you'll be happy to know. But I tell you this story because this is the consequence of lobbying. This is what happens when advocates rise up and say, you're not meeting our needs, you need to be providing us better care, and this is the power of advocacy to make change in all of our lives. And I just want to emphasize that because one of the books that the National Cancer Institute put out as part of what we call our Facing Forward series, which is designed specifically for individuals who are finishing their treatment, is a book called Ways You Can Make a Difference in Cancer. And the reason we put this out, and I don't know any advocacy community that ever did anything like this, we put this out because people kept saying, I've had this disease and I want to make a difference in other people's lives, whether it's because I'm grateful to be here and I want to ensure that people have the same good fortune that I had, or I didn't like my care and I want to make sure nobody ever gets that negative care again. But ways to give back and get involved, whether it's talking to another, being a peer counselor if you like, veteran to rookie, survivor to survivor, or whether it's driving people to an appointment, or whether it's serving on national cancer advisory boards or peer review scientific committees here. So we put this book out to suggest what are the ways that anybody could get involved, whether they're a survivor or a loved one of a survivor or a community member. And this is sitting on a shelf. It's your public dollars at work, so call them up and say, send me a copy of that. And if you want to know more about the Office of Cancer Survivorship, I hope you'll come to our website. It's survivorship.cancer.gov, survivorship.cancer.gov, to find out what we are funding in this area, where we think the research is going, and ways that we hope that we can meet your needs. So these 7 lessons that I think are very important. Language is important, and we need to attend to it. Transitioning is stressful, and we need to do a better job with that. Being cancer-free does not mean being free of your cancer. There are, despite the enormous challenges to cancer, benefits that come with this disease and enormous resilience that so many people manifest. There are a number of factors, however, that may help achieve optimal outcomes. Cancer for many can be that teachable moment. And perhaps most importantly, we need to listen to survivors. Thank you.